Good evening, ladies and gentlemen. How are you all doing? Happy Wednesday, hump day. I hope you all had a fantastic day. I am Ann Bingham, the country manager for SERVIER, and it is indeed my pleasure to be your hostess this evening. Joining me on location and helping in the coordination of this meeting are your three medical representatives, Lisa Prince, Clifton Mesquita, and online we have Fiona Bennett. This evening's presentation promises to be a mouthful of amazing information. So get your notepads, get your pens, get ready to get some wonderful information downloaded and gear up to really implement those findings and information in your practices tomorrow. The theme for this evening's meeting is the two CVDs, cardiovascular disease and chronic venous disease. Do they have more in common than we thought? So we'll be exploring that topic this evening. And just to make you aware that this evening is brought to you in association with the Caribbean College of Family Physicians. And before I introduce our two dynamic presenters this evening, I would like to invite Dr. Seni Onanuju to share with us greetings on behalf of the Caribbean College of Family Physicians. Dr. Onanuju, over to you.
Good evening, everyone, to our specially invited guests, Dr. Victor Elliott, Consultant Interventional Cardiologist, and Dr. Delroy Frey, Consultant General Surgeon, distinguished colleagues, staff of SERVIER Pharmaceutical, our host of this evening's virtual clinical meeting, IT and technical support personnel, Mr. Samuel Aaron of OJ Solutions Limited, friends, ladies and gentlemen, a pleasant good evening to you all. Chronic coronary syndrome refers to a condition where the heart's blood supply is reduced due to narrowed or blocked coronary arteries. This can lead to symptoms like chest pain and shortness of breath. Chronic coronary syndrome presents various clinical challenges, including the differentiation of treatment modalities for patients with stable and unstable symptoms. Recent guidelines emphasize the need for updated management strategies, focusing on individualized treatment plans based on the patient's specific condition and risk factors. Chronic venous insufficiency is a condition where the veins in the legs struggle to send blood back to the heart. This occurs due to damaged valves in the veins, which can lead to blood pooling in the legs. Over time, this can cause increased pressure, resulting in various symptoms. Chronic venous insufficiency is associated with an increased risk of cardiovascular disease and mortality, especially in older adults. This condition occurs when leg veins are damaged, making it difficult for blood to return to the heart, which can lead to complications affecting overall heart health. The relationship between chronic venous insufficiency and heart health is significant due to a number of factors such as damage to vein valves, obesity, age, and prolonged standing, to mention a few. Our best hope is through early diagnosis, intervention, appropriate treatment modalities, and physician and patient education. The Caribbean College of Family Physicians has various mandates. Among them is the enhancement of knowledge and skills of doctors throughout the region via the use of various media as well as collaboration with other organizations. This evening, we are pleased to join SERVIER as they explore the challenges we are confronted with while managing our patients with chronic coronary syndrome, cardiovascular disease, and chronic venous insufficiency, as we'll examine current guidelines and establish relevant clinical correlation to best tailor our treatment modalities to suit the individualized needs of our patients with the hope of achieving improved clinical outcomes. As such, we have with us this evening two distinguished, well-known, knowledgeable, and experienced speakers. Consultant General Surgeon Dr. Delroy Free and Consultant Interventional Cardiologist Dr. Victor Elliott, both of who hail from our very own Jamaica. Thanks to SERVIER Pharmaceutical for inviting them to share their time, talents, and expertise with us. I am confident that we will be well informed and enriched by their presentations. Dr. Elliott, Dr. Frey will welcome you wholeheartedly. A special welcome to our members and all other participants who continue to support us. On behalf of the college, I thank, welcome you all, invite you to sit back and enjoy the presentations. Thank you, and as always, God's richest blessings.
Thank you for that warm greeting from the Caribbean College of Family Physicians. Thank you, Dr. Onanuju. It is my distinguished honor to present and introduce to you our first guest presenter for the evening, Dr. Victor Elliott, consultant interventional cardiologist, a proud graduate of Wolmer's High School for Boys. I'm not sure why Clifton is applauding. So for the Wolmerians online, yes, I hope you're rearing up for champs this weekend, or the finals rather. So Dr. Elliott is the Chief Executive Officer of the Partners Heart and Health and a consultant interventional cardiologist at University Hospital of the West Indies, Mona. Dr. Elliott brings a wealth of knowledge and expertise shaped by a robust academic background and extensive professional engagements. Following the completion of a degree in chemistry and applied chemistry at the University of the West Indies, he entered the Faculty of Medicine, where he obtained his MBBS from the University of the West Indies and a Doctorate of Medicine in Internal Medicine. He then pursued further studies in cardiology at the University of Toronto, where he completed his fellowship in interventional cardiology. This evening, his presentation will be focused on the topic, clinical challenges in the diagnosis of chronic coronary syndrome and guideline recommended approaches for treatment, the clinical approach. Without further ado, help me welcome to the podium Dr. Victor Elliott.
Thank you. Okay, good evening, everyone, and to those who are online. Now, if I do sound a little stuffy, it is because I am. I'm kind of recovering from a cold and flu, and the headache and the stuffiness is the worst part. But you know, Professor Gray used to say the best decongestant is fluids. And I do find when I drink a lot of fluid, I do feel better. It's less pressure in the sinuses, but boy, you run to the bathroom every minute. How are you supposed to get rest if you're running to the bathroom? Anyway, clinical challenges in the diagnosis of chronic coronary syndrome. Now, as I shared with Ms. Prince yesterday, this talk has undergone several evolutions from I started preparing it over a month ago. Because as the deeper I went into it, it really changed from what a presentation I did a couple years ago. Because things have changed and things in the guidelines have changed. And I'm hoping that you can follow suit and not lose you along the way, but yes, there are clinical challenges. So we're talking about angina, and we're not going to be focusing on the acute coronary syndrome. But angina, we know, really has three aspects to it. It is usually from obstructive coronary artery disease, you know, the narrowing of the arteries, which we're all familiar about. There's microvascular angina, in which the symptoms are in the smaller vessels, the problem, the blockages, or some issue with how they function. And then we have vasospastic angina, which we have learned is what Prince metal angina or variant angina due to spasm. So you're talking about three aspects. Sorry. There we go. So you're talking about three aspects in terms of the spectrum of angina. And of course, involved in these are different things ranging from your metabolic dysfunction, inflammation, and this is where the link is going to be even with the venous aspect of things, endothelial dysfunction. So ischemic heart disease, as said, we have the stable coronary syndrome and the acute. And under the stable, which a lot of us are familiar with, are the patients who have the angina that occurs with exertion. They kind of know what brings it on, and so they try to control their activity. But we still have people with stable angina who sometimes even get angina at rest. It's not the MI, they go to the hospital, no acute ECG changes, no elevation in the troponin, none of that delta change, but they are a problem. And when it comes, we basically can categorize them in two groups, what we call the obstructive coronary artery disease and the group in which we call INOCA. Now, we'll explain that a little more. So as I said, just again emphasizing what we're dealing with a lot is what is happening in the microcirculation with a lot of these patients. But you can still have the spasm, you can have the occlusive coronary artery disease. And my talk today is not going to focus on the occlusive. Yes, I'm an interventional cardiologist. I will stay here and talk about blowing up vessels and opening and stenting till I'm blue, because it's what I enjoy doing, but it's not the focus. So if we just follow this diagram again, we talk about the occlusive, and the occlusive tends to be a little bit more common in men. But here's a funny thing that happens sometimes. We have a patient who comes in with chest pain, sounds like an acute event, smells like an acute event. We carry them to the cath lab, and their vessels are normal. There's no occlusion that is seen. And we tend to see this a bit more in women. So what is the issue for these people? And trust me, we do see them. And we have seen them, I would say, just as much as some of you believe that we're seeing more MIs, and we're also seeing more of this group. So it's a dynamic group, and we have to be aware that there are a set of people whose issues are generally not the large vessels, but the smaller vessels. And we have two groups in which we talk about with this, what we call ANOCA, angina with non-occlusive coronary arteries. So yes, they're the ones that come in, they have the chest pains, we rush them to the cath lab, because some of them can present as if they're acute, when we call those the ANOCA. But some of them come in more chronic. You listen to their story, and if you're a betting person, you would have sworn, yes, they're going to have an occlusion, and nothing is there. Also in this group is the INOCA, ischemia with non-obstructive coronary arteries. And just understand, they are together, there's an overlap in which one is actually having symptoms, but not necessarily ischemia, while the other one can demonstrate ischemia. So when it comes to coronary artery disease, believe it or not, the obstructive is really the tip of the iceberg. This group of the INOCA and ANOCA actually makes up the greater percentage of people with chest pain of a cardiac cause. If that's surprising, good. Let that sink in. And women take up a larger percentage of that group. So in those anocha patients, those are the ones with angina, most of them have some form of endothelial dysfunction. Some will have some vasospasm, which could either be of the large vessels or the small vessels, or some even have what we call abnormal vasodilation, meaning what? Meaning that your vessels are supposed to dilate on demand. As you exercise, as you get around what you're doing, the nitric oxide levels are supposed to increase, stimulating the blood vessels to dilate, but their blood vessels don't. So yes, one person is having spasm, the other one just not dilating. And 25% of that anocha group end up with inoca, actually having ischemia. So again, when it comes to the microvascular, like with the large vessels, you have structural issues in which you can have plugging, fibrosis, you can have plaque that is there in the small vessels, even though you don't see significant plaque in the epicardial vessels. But a large number of them also have functional issues. And as I pointed out, it's impaired vasodilation, increased constriction, some form of dysfunction of the small vessels. And so this is what we call coronary microvascular dysfunction. And this is where, as I said, the clinical challenge comes along. How do we diagnose these patients? So the endotype of inoca actually has grown from 3 types to now 6. As I mentioned, endothelial dysfunction, microvascular angina, the vasospastic angina, those who have both, those who essentially have an angina without fulfilling the criteria of either of these two, and those with impaired vasodilation. So understand, let's just go through this again. Endothelial dysfunction, the endothelium is not functioning well. There's a problem with nitric oxide, etc. And I know a lot of you on your social media see a lot of the postings about nitric oxide, and some people are saying this is the big thing that they're not telling you about. Over a bit emphasized, but it is a big aspect of things. As I said, microvascular angina, that could be structural, such as plug-in fibrosis, or it could be a constriction, a failure to a structural issue, fibrosis, and so on. You have spasm, either the big vessels, the small vessels, but yes, you can have spasm of the small vessels, and they tend to respond to certain medications. Patients can have both, and you have those which just don't fit into any of these, and the impaired vasodilation. So they don't have fibrosis, they're not constricting, but they're not dilating on demand. So how do we approach patients with chronic coronary syndrome? So we're going to go through a stepwise approach. So step 1 starts with history, symptoms, physical examination. Of course, anybody coming with chest pain, we want to know, is this really angina? Is this epigastric pain? Is it pain that comes with wheezing? Is it shortness of breath? Are they having no angina type chest pain? We want to do our investigations, the ECG, the biochemical investigations. We do ask for pulmonary function testing, some of them, just to make sure that that chest pain is not due to bronchoconstriction, because we do see that. So essentially, doing the right things to just distinguish, is this a cardiac issue or not? And by us going through what we have learned over the years, we'll either put these patients into a non-cardiac group. It's epigastric, it's regurg, it's pulmonary, it's musculoskeletal. Or, depending on the fragility of the patient or the comorbidities, They may actually be having something in terms of angina, heart failure, but at that point, not much can be done. But we're not talking about that group. But if you have symptoms, not cardiac, but you think if you have symptoms and you think it's cardiac, and the patients are patients who you know have greater than 6 weeks lifespan, you're going to go to further evaluation. So as I said, we look on the symptoms. Now, when it comes to cardiac symptoms, things can be a little funny. And we're learning this more and more every day. The angina, the pressing chest pain, the typical thing for one, we know not everybody has that, especially 3 major groups, the diabetic, the elderly, and women. They may present differently. What we have to do sometimes is think about what we call angina equivalent symptoms. So they may have burning, they may have a sharp pain. What I find some women talk a lot about is this low feeling in the chest. Actually, the more I hear that, I tend to think of PE more than cardiac, actually. You have to look at the location of these pains. Yes, angina is usually said to be on the left side, going down the left arm, come up to the jaw, but I've met patients on the right. I've met patients with both. I tell people that angina didn't read the textbook. Usually the duration, angina type symptoms, it's usually intermittent, not something you wake up with and have for the past 7 days continuous, that kind of thing. But again, sometimes it really does fool you. And I've seen a lot of doctors miss angina because it hasn't presented typically. Or, as I said, no chest pain or chest tightness at all. So the whole area of, like, say, dyspnea, shortness of breath on exertion, some amount of wheezing. Yes, you think wheezing is normally pulmonary, but sometimes, as people call it, cardiac asthma. I actually hate that term, but I understand what people mean by it. But is that shortness of breath triggered by exertion? And yes, even if it's cardiac, it can cause wheezing. You have to think of the nausea that comes along. So, and notice what I even have here, sleep disturbance. And coronary artery disease can present with sleep disturbance. So you have to be aware that not all the time you're going to find angina. And if you're investigating the patient and you're treating them for GERD for a while and it's not easing up, you think it's pulmonary and you're giving them the inhalers and it's not easing up, start to think cardiac. I've had patients who have come to me, their GPs treating them for the past 2 years. But what's the critical thing? They haven't improved with what they've been getting. And the GP just hasn't done anything more. While I've had from some people, including some in this room, who started that, and then the referral say, you know, but after 2 months, the patient said, I'm not doing better. Dr. Elliott, see if this is the heart. There comes a time when you now have to think out of the box. So once you have now assessed that this may be cardiac, your question is this obstructive cardiac disease or non-obstructive? In that, yes, you can have chronic coronary artery disease, not the acute MI, which is the plaque rupture, the thrombus formation, make you start to have an MI, but that stenosis is there, no pain at rest. Once you exert, it's not allowing enough blood to reach the heart, they have the angina. So you want to know, is it obstructive? So you're going to have to do an assessment of your patient to see what's the likelihood that this could be obstructive or not. So if you do your assessment and there's low likelihood that there's obstructive artery disease, you may want to consider further testing. As I said, if you do find and you think it could be obstructive, but there's other comorbidities which make you say, look, there's not much to even suggest, because suppose I do find triple vessel disease, this person can't do bypass surgery, that kind of thing, and occasionally we do have those patients. They may have metastatic disease, some other stuff, but at least you know what you're going to try and relieve their symptoms with. But if you think that there is a high probability that there is some amount of obstructive or coronary disease, you then go on to the next step to actually do the proper assessment. But how do I assess the likelihood? So yes, there's now a scoring system for this. There's a scoring system for almost everything in medicine these days, make it so much harder for my residents to learn. So here's one of the scoring systems which is being used, and it has been validated and has been shown to be quite useful. And this is where the part of the challenge is. So part of it, you look on the characteristic of the pain. The type, the location, is it relieved, aggravated by rest, by medications, by nitrates? And notice when it's relieved by nitrates, it is relieved within minutes. I have patients who will tell me that GTN works. The question I like to ask, so if you have pain now and I gave you a GTN now, how soon will it relieve the pain? Oh, in about 30 minutes. That's not the GTN. The GTN is supposed to relieve within minutes. So you have to also make sure you get from your patients their understanding of what is happening. And so there's a point system. There's a total of 3 points for one of those. You also look on the dyspnea characteristic, the shortness of breath or the issues with catching breath after physical exertion, and that's a 2 points. So you look on the number, and you also look in terms of risk factors, family history, smoking, dyslipidemia, hypertension, diabetes. And I'm sure over time more things will be added to this risk factor, but you know the risk factors. And then you go to your chart, your scoring chart. So notice what they have. You have your symptom score. If they got 1 from the symptom, 2 from the symptoms, or 3 points from the symptoms. If you look on the risk factors, in which you get a total of 5, notice male, female, different, and also the age. And you put in your score. And based on that, you can see if it's a very low chance in the blue of it really being coronary artery disease, or if it's low or moderate. Funny enough, you notice there isn't a high. I found that interesting too. But now, if I have a patient who I think it's low or moderate, I don't stop there. Neither do you, quite frankly. So you're right, the scoring system is not new. It's just kind of putting things together, things that you actually do. You then do your other assessments. You do your ECG. You're going to send them maybe for a stress test. You're going to send to look for LV dysfunction. If they're having arrhythmias, do they have other comorbidities, peripheral artery disease, carotid artery disease? Or, here is something which has come up quite interesting. Coronary calcification on a previous chest CT or even a chest X-ray. They're now saying if you have done a chest X-ray and they kind of indicate that there's calcification, you need to follow up with that. Or if you did some form of CT chest and they comment on it, you need to follow up on it. It wasn't a coronary CT, could have been to look on the lungs and they saw calcification there, you need to follow up on it. And notice all of these are class 1 indication, meaning that all of this has been validated. So the more of these points that are put together is the stronger that you're putting that your patient actually has is coronary artery disease. Now, they've also said, and it's a class 2A indication, that if your patient falls in the low, one of the things that they're encouraging you to do, and this is a little new, is to do a coronary calcium score. Because that calcium score can make your patient go from low to very low if the calcium score comes back 0, or from low to moderate if the calcium score comes back elevated. So in short, that patient who you're not quite sure where on the fence they sit. So once you have evaluated your patient and you think based on the scoring system that there is a chance that they definitely have coronary artery disease, then you have to decide, as I said, what you're going to do. So you can do for the CT, the coronary calcium score, plus or minus a coronary CT. And you notice that is really for low to moderate patients. It's not for high-risk patients. Even though one talk that I actually listened to yesterday, in the American system, they're starting to change that. There are some doctors are now feeling that this is something which you really should do in more patients rather than in less. But again, if you're not certain, do your functional imaging, which is a stress echo, nuclear stress test, something that will help to increase the likelihood of diagnosis. But if the likelihood is high that they have coronary artery disease based on what you have found, send them to do a coronary angiogram. As simple as that. What I actually tell my residents and I tell people, when it comes to the functional imaging aspect of it, here's one thing to me that helps. You listen to a patient's history, you hear, you suspect. You're going to send them for a stress test. If that stress test came back saying it is negative, are you going to believe that stress test? If you're not going to believe the stress test, send them straight for an angiogram. If you feel that you can believe the stress test based on the patient's presentation, then you do the stress test. That's not validated. That's a simple little rule I use, and I find it's very helpful. And I explain that to the patients. But I still give them the choice. I tell them, look, I'm hearing what you have. I'm almost convinced you have. I can do the stress test. But my problem is that if the stress test come back negative and you continue to have pain, I'm not going to believe the stress test. So the stress test is really more for the patients with moderate. And once you think it's higher than moderate, you send them straight for the angiogram. So the guidelines, and these are the new European guidelines from 2024, that's what we mean by new, to rule out obstructive in low to moderate. They recommend that you do add the coronary calcium score and maybe a coronary CT scan. But invasive is for those in which you want to exclude or include obstructive or to see if it's really ANOCA or INOCA. Now, for those who you cannot necessarily get a CT calcium score done on, while it's a class 2B indication, getting an assessment of their, sorry, wrong slide. Well, I'm going to say what I wanted, but this isn't the slide that has it. Doing an assessment of the coronary arteries, not the coronary, the carotid arteries can be something to help you. So if you do a carotid artery Doppler and you find significant atherosclerotic disease, it's a high probability that they also have coronary artery disease. They are not saying it's as accurate as doing the CT calcium score. But if you're unable to get that, that is a surrogate which can help you to decide what is happening. So again, just in a chart form, if you assess your patient and they're very low, no further testing, you look for some other cause of their chest pain. If it is low, you do some other assessments, the stress ECG, you can do the echo functional testing or the coronary calcium score and coronary CT. If it's moderate, you do get some functional imaging. So not just a exercise stress test. You want functional imaging, whether a stress echo or a stress nuclear scan or a cardiac MRI. And that is available for us. It's available in Montego Bay. And people, you may say, for us in Kingston, it's far, but look how many patients travel from Montego Bay to Kingston for treatment and investigation. The road works both ways. Once you have high risk, they're saying you do the functional imaging above the CT scan, and this is where I said the Americans are starting to think. It's not in their guidelines, but also adding this up here. But once you think there's a high chance that that patient with the with the symptoms could have coronary artery disease, go straight for the coronary angiogram. So again, this is just another way of putting it. You have the suspicion, you do the CT. If the CT shows a high risk, you get your imaging. If it's not clear, or if you want to do imaging and it's not clear, they can complement each other to make sure. Or if, again, you do the imaging, the stress test comes back positive, you go for the coronary angiogram. But of course, once they're high risk, you go straight for the coronary angiogram. Oh. However, this is where part of the problem now comes. You do the coronary angiogram, you find obstructive disease, that's fine. You know what to do. We blast them open, put in a stent, or send for bypass surgery. But if there's no obstructive disease, we are now left, how do I know if this patient has microvascular disease? Or is it really a non-cardiac chest pain despite everything? Sorry. So here's the chart, the one that's about the carotid arteries may be considered an alternative for the calcium score. Sorry, I kind of had that in the wrong place. Please forgive me. Okay. So when you now come out with your diagnosis, there is also now in terms of the treatment, as I said. The revascularization, medical treatment, which we'll talk a bit about, but of course, lifestyle, exercise, diet, and modifying the risk factors, controlling blood pressure, controlling cholesterol levels, controlling glucose levels. And we know recently the new guidelines in terms of the cholesterol levels came out, and it's really pushing. Start assessing early, get that LDL down lower, do your lipoprotein small a assessment. There are new things in these things which we now need to be doing, which not the focus of this talk. Where is my handkerchief? So for the obstructive, as I said, not my focus here. We know what to do. We are to do a coronary angiogram, preferably with some form of imaging, intravascular ultrasound or OCT, especially if it's bifurcation or complex. Or we can do some form of physiological assessment. And, well, as I said, not the focus of this talk, but adding either imaging or physiological assessment, especially if we see some stenosis that we're not sure if it's significant or not, has been shown to make a big difference in the outcome for your patients. But I want to focus a bit on this guy, Inoka Anoka, because this is a troublesome area. In that we have the patients who have the symptoms, and then we do their angiogram, and we see no obstruction. How do I manage this patient? Do I just assume, oh, your chest pain is not cardiac? How do I say, okay, it could be vasospasm? Do I assume it is small vessel disease? What they're telling us now is not assume. You have to diagnose. And this is a bit of a challenge. But it is necessary because it's going to affect what you put them on. For example, as you see here, if there's a problem with vasodilation, your beta blockers, your calcium channel blockers, ranolazine, trimetazidine, ivabradine is helpful in those patients. If it's abnormal vasoconstriction, what you need are your calcium channel blockers and your nitrates. Things like ranolazine, trimetazidine doesn't help in those patients. So you need to know the right medication to put your patients on because you need to know what the issues are. And I'm going to tell you from now, in Jamaica, we do have a problem with this. And I'll explain a little more why. So we need to know which of these problems do they have. So especially like if they have a combination, maybe we need a combination of the medications. And some of you may have angina patients who you have on one thing or two and you're still not getting relief because we haven't properly diagnosed which microvascular issue they actually have. So to find out which one they have actually takes another level of testing, which is done in the cath lab. I can do physiological testing of the large vessels. Unfortunately, we are not yet able to do the physiological testing of the small vessels. When I say us, I mean us in Jamaica. The technology exists. It is there, and I'm hoping to get it, but we don't have it yet. So I'm talking to you about a problem which I'm not providing a very good solution. But what it does involve, because I know we're doctors and we like to have a bit of knowledge, it basically involves passing wires down into the vessels, and we may either do thermodilation and measuring resistance, flow reserve, injecting acetylcholine to induce spasm. And that part is easy. The problem is we don't have acetylcholine in Jamaica. But this part of the test is relatively easy. There's a protocol, how much you inject over what time period, and see how the vessels respond. If you see them undergo spasm, then you know that's an issue. And then hence you can actually figure out what to do. But let me say I'm working on it. Because I did some inquiry about the acetylcholine. It is possible to get it in Jamaica, even though we don't have it yet. But we're working on it. Because I'm realizing when it comes to these microvascular cases, we need to know who we're treating and what we're treating. Or you do the test, and they don't have any microvascular problem. Then we know definitely it's not a cardiac issue. Because I can tell that is the challenge I have. I see these patients do their angiograms, it's normal, and they're still having pain. Do I just say, oh, it's not cardiac, or is it microvascular? Sometimes, fortunately, when we're in the cath lab and we inject, we can actually induce spasm. And then they have the symptoms, and you're like, is that the pain that you've been having? And they say, yes. And I'm like, yes, nailed it, quite accidentally. But that doesn't happen all the time. So for these patients, they tend to be quite symptomatic, and they tend to have a poor quality of life because the angina is persistent. And here's even the worst part of it. The studies have shown patients with ANOCA, especially in NOCA, have a higher mortality. So while the major vessels may not be blocked, that microvasculature causes a problem and causes cardiac dysfunction. And they have a higher 5-year mortality, even though their big vessels are nicely open and cleared. So it is something which we really have to try and find something to do. I should not say that we're totally lost to PET scanning. There's one place in Jamaica that does PET scanning, and we can do the cardiac MRI. So if you have a patient who has been having angina, the angiogram is normal, you can send them for the cardiac MRI asking for ischemic assessment. If they're having inoca, they will see ischemia. And the PET scan can also show ischemia. What it isn't going to tell you is what is the nature of it. Is it the vasospastic in the microvasculature? Is it poor vasodilatation? But at least you will know it is cardiac, or it's not cardiac. You'll do it, there's no ischemia, then you know you have to go somewhere else, find a different cause for the chest pain. Am I making this worse for you? So as I said, we can do testing for the vasospasm, not yet in Jamaica, but hoping to see if we can deal something with that. But of course, the vasospasm is also a simple way of, or an indirect way of testing it, is to give them nitrates. They respond well to nitrates and calcium channel blockers. Right. So to relieve their symptoms, we do have medications, as we mentioned. As I told you, for these patients that have endothelial dysfunction, ACE inhibitors should be among the medications you give. Because ACE inhibitors are ARBs, but they point out mainly ACE inhibitors work better for the endothelial dysfunction in these patients. So again, it's one of the medications you can try on your patients who we are unable to do appropriate testing on at this point in time. If they're having spasm, as I said, a calcium channel blocker is your first line of treatment, not your nitrates. The calcium channel blockers like diltiazem and verapamil are your first line choice. Then a nitrate can also be considered, and you may combine the both of them. In terms, and I said, lifestyle changes is important, especially for these patients with vasospasm and endothelial dysfunction. Exercise has been shown to be helpful, and so it's one of the things, getting them to do those exercise 75 to 150 minutes per day is very helpful. So the cardiac rehabilitation is helpful for these patients. So again, the pathophysiology linking in terms of these sets of patients is very important. I'm stepping up as time is going. So we also need to do our assessment, because if we're thinking in terms of what could contribute to endothelial dysfunction, what could contribute to dysfunction, the microvasculature, we need to do our full set, including our A1C, thyroid function assessment, because thyroid disease can affect microvasculature, and doing things like your HSCRP, signs of inflammation or fibrinogen plasma levels, are being found to be helpful in these patients who you think have microvascular disease. So the recommendation, if we think it's endothelial dysfunction, ACE inhibitors. If it's microvascular angina, beta blockers can also help with the symptoms. If it's vasospastic, calcium channel blockers, and then nitrates. And if you think it's an overlap, then we can combine a lot of the medications. And unfortunately, I guess that is where a lot of us are going to end up with our patients until we can do better assessment, is to just try different combinations of medications. So here's your combination chart. Depending on what you think is happening, the beta blockers, the calcium channel blockers, the trimetazidine, ranolazine. So these are very helpful in the obstructive and in those which have microvascular dysfunction, not those with the spasm. But where you think, what I found with some of my patients, you do the combinations and see which ones help. But yes, this is what I'm showing by the diagnostic dilemma. We are now being challenged. Don't just say it's microvascular. We have to try and see which microvascular. And unfortunately, we're not yet fully able to. But what you can do to at least see if it's microvascular is do a cardiac MRI or send them for a PET scan. Again, this is just reinforcing. I just go over this quickly. And just again to point out that, you know, remember when you're doing long-acting nitrates, they should have a nitrate-free interval. Ivabradine should be considered as an add-on if the ejection fraction is less than 40. So it's not those for those with normal cardiac function. And trimetazidine is also an add-on for patients with beta blockers and calcium channel blockers as part of part of an initial treatment in your patients. A funny thing about the new guidelines, they have gone away from what they had as a step 1, step 2, step 3. That's not what they're saying here. They're saying depending on the type, you choose your medication, then you have the add-on to the medication. But even in such a case, you can assess your patient. These add-ons may be just part of that initial. So you may do a calcium channel blocker and trimetazidine as your first step, depending on what you think is happening with your patient. So let's kind of summarize a bit of it. When it comes to chronic coronary artery disease, it is very complex. I tell you, that was part of the problem I had preparing this. I could do a presentation that would take 2 hours. And I went from 60 odd slides and cut it down to less than 50. And because you also have to look on other conditions that's happening with your patients, and that also influence what you add. So it's not just if they have microvascular, if they have atrial fibrillation, the set of medications you use will change. If they have heart failure, if they have a pulmonary disease. Oh, and I should have added the beta blockers that they're advocating. It's mainly the 3rd generation beta blockers, because they have a kind of a microvascular vasodilatory effect. So we're not talking about definitely the 1st generation, not propranolol, not atenolol. We talk more the 2nd or probably more the 3rd generation, the carvedilol, the nebivolol, in terms of treating these patients with angina. So in addition to the medications which reduce symptoms, we want medication to improve prognosis. Because remember what I said, patients with ANOCA and INOCA do have a higher mortality. So getting that normal coronary artery disease is not the end of it. And one of the things they emphasize is that you must continue follow up with these patients. Put them on medication, see how they're responding, change the medications, but also realizing, especially if you have demonstrated that they are having ischemia, is to the medications and lifestyle changes that will change prognosis. Of course, if it's obstructive, we have our antithrombotic, antiplatelet medications that we are going to use on them. And here's what is also I found quite interesting. In patients without a prior MI or revascularization, but have evidence of obstructive coronary artery disease, aspirin is now recommended lifelong. So they're having the angina, and they have evidence of obstructive coronary artery disease, aspirin changes more outcome. You are to add, as I mentioned, the guidelines in terms of your LDL lowering, and especially if they're high risk, if they're shown to have obstructive disease, we're aiming to get that LDL below 1.4. And so if you need the statin, ezetimibe, inclisiran, which is your PCSK9 inhibitor, which we have available in Jamaica, you add, you combine. If they can't take the statin, you use the PCSK9 inhibitor. Whichever way, you get their LDLs down. Here is also a part of your treatment of these patients. Yes, your angina patients, the SGLT2 inhibitors, especially in those with type 2 diabetes, has been shown to reduce cardiovascular events independent of your baseline or target A1C. So your SGLT2 are to be used in your diabetics who are having angina, whether they have the obstructive or the ANOCA or INOCA. So it's part of the treatment, because while it may not often relieve the symptoms as you know it, it affects the outcome, that increased mortality. The GLP-1 receptor agonist, like semaglutide, is also for your patients even without diabetes, but who are overweight and obese, because it reduces cardiovascular mortality. An anti-inflammatory, colchicine is now part of your armament in these patients, whether they actually have obstructive or ANOCA or INOCA. Now, colchicine is not available to us out here. Used to be years ago. We don't have it now. I hear there's one pharmacy you can get it, though. Actually, I have a patient who got it at one pharmacy. So, who knows, maybe we'll start getting it again. But the studies have shown that it does reduce the inflammation in the microvasculature and affects outcome, not just symptoms. So, our patients with ANOCA and INOCA, in that we know how to do the obstructive. Open them, put in the stent, but even some of them still continue to have angina. Those with normal coronary vessels, we have to suspect they're microvascular. The treatment, lifestyle changes. We assess their risk and deal with their risk management. What we would love to do is to be able to understand what is the nature of the microvasculature so we can start putting them on the appropriate medications. Right now, the best we can do is to either demonstrate whether they have ischemia or not. And then based on that, at least we know if it's cardiac or not, and then put them on medications, do your combination, follow up. If this combination isn't working, change to another combination until you find the combination that works, but that relieves symptoms. You make sure they're also on the medication that changes outcome. Right, I think this is my last slide. Okay. So recurrent events. You deal with the symptoms, look for the ECG changes. Oh, what may be helpful for the vasospastic is doing things like a Holter, especially if you think they're having the vasospastic symptoms often, and look for that ST changes when they have the symptoms. That can actually be diagnostic of patients who are having vasospasm. But again, it's also considering and treating the comorbidities, lifestyle changes, and important, frequent follow-up. Don't let them go. These patients having chest pain have normal coronary arteries. Don't think, all right, the angiogram was fine, you're fine. They may not be fine. ANOCA and INOCA have a higher mortality. They must be followed up. So as I said, it's not benign. Should not automatically think if the angiogram is normal that you must classify them as non-cardiac. What we, especially in the women, we really have to start getting ourselves to find out what's the nature of what they have. It has a wide variant of clinical presentation, so remember they may not have the typical chest tightness or pain, but the dyspnea and other associated symptoms. And so as a result, I guess the challenge is on us, the cardiologists, to now come up with ways of adequately elucidating the endotypes of our ANOCA and INOCA, and I'm promising you we're working on it. And if you just allow me 1 minute to just end. Oh, where's my last slide? Okay, I had a little thing at the end of mine, which obviously didn't get uploaded. Okay, that's it. Thank you very much.
In 24 hours, the heart beats over 100,000 times and pumps nearly 9,000 liters of blood to supply the cells with oxygen and nutrients. To contract and relax continuously, the heart muscle cells, the cardiomyocytes, must constantly produce energy in the form of adenosine triphosphate, ATP. In normal conditions, the heart produces between 6 and 35 kilograms of ATP every 24 hours to satisfy the energy demand. When ATP production does not meet the energy demand, there is an imbalance between energy supply and energy demand. This is called myocardial ischemia. Myocardial ischemia is a complex syndrome with multiple causes, which include coronary stenosis, thrombosis, vasospasm, microvascular dysfunction, endothelial dysfunction, and inflammation. Regardless of the causes of myocardial ischemia, it is fundamental to reduce the ischemic burden directly at the cardiac cell level by increasing ATP production. This is precisely what Vastarel 8-TOD does. Vastarel 8-TOD uses an advanced controlled release technology to cover the needs of patients over 24 hours. Its granules are made up of inert core beads that are coated with the active substance, trimetazidine, and covered with a polymer membrane layer. This membrane, which contains micropores, enables the controlled release of trimetazidine. For patient convenience, the controlled release granules are enclosed in a capsule that contains the total daily dose of Vastarel, which is 80 milligrams. This is Vastarel 8-TOD. The treatment regimen is simple. Just one capsule of Vastarel 8-TOD once daily in the morning covers the needs of patients for 24 hours. Once in the stomach, the Vastarel 8-TOD capsule dissolves and the coated granules are dispersed into the gastrointestinal tract. There, the micropores of the polymer membrane allow fluid to enter the granules and come into contact with which gradually dissolves and is subsequently released by diffusion. Thanks to this advanced controlled release technology, continuous diffusion is achieved and the absorption phase in the intestinal villi is prolonged. This ensures that Vastarel 8-TOD's powerful anti-anginal efficacy is maintained over 24 hours. One capsule of Vastarel 8-TOD per day reduces the ischemic burden directly at the cardiac cell level, where it matters. Over 24 hours, Vastarel 8-TOD increases ATP production by 33%, reduces acidosis, and enables cardiac cells to function properly. Thanks to this unique mode of action, Vastarel 8-TOD reduces angina attacks, preserves cardiac function, and improves exercise capacity. By prescribing Vastarel 8-TOD, one capsule in the morning, you will provide your angina patients with a simple once-daily treatment regimen and anti-anginal efficacy over 24 hours.
Okay, good evening, doctors, both physically here and those online. Thank you. All right, so at SERVIER, we appreciate that the patient is the center of everything that we do. I think you'll agree with me. However, we appreciate also that they are afflicted with multimorbidities, which can manifest with various chronic conditions, as you obviously will have seen them in your office. So, we at SERVIER, we're offering you a portfolio of multiple products that can be applied for many different chronic conditions. And tonight, I'd love to focus on the coronary artery disease and the use of Vastarel OD80. All right, so let me tell you about this patient. This is Harry. Harry is a 55-year-old architect. Now, I'm sure you're probably going to see patients with similar conditions, but just listen to what's happening to Harry now. It's a cool Tuesday morning in Mandeville. Harry is walking up a moderate incline from the car park to his office, carrying a briefcase that feels unusually heavy today. Harry doesn't feel the pain in his heart. Instead, he stops abruptly near a bench, not because his chest hurts, but because he's suddenly and inexplicably winded. Harry is clutching his chest because he's experiencing the subtle, often confusing symptoms or signals of angina equivalence. First, there's the breathlessness or dyspnea. He draws in deep breaths, but it feels like the air isn't reaching his lungs. His tie feels several sizes too small, though he hasn't gained any weight. This is the primary angina equivalent. His heart is struggling to pump, and his lungs is paying the price. He also may have the radiating discomfort. So he rubs the left side of his jaw and the back of his neck. It's a dull, nagging ache, the kind you usually blame on poor sleep or stress. But it intensified the moment he started to walk uphill. He also experienced indigestion, or apparently indigestion. So he feels a burning sensation in his upper abdomen. He reaches for a roll of antacid in his pocket, thinking it's a spicy omelette he had for breakfast. In reality, this epigastric distress is his heart signaling for more oxygen. And finally, he has the cold sweats. Despite the cool morning air, a fine layer of clammy perspiration breaks out across his forehead and the nape of his neck. He feels a wave of nausea, a slight spinning in his head that makes him grip the handle of his briefcase tighter. So what does Harry do? Harry sits on the bench, unable to go any further. The demand on his heart after he sits, it starts to decrease. So within about 3 to 5 minutes, it subsides. The indigestion fades, his breath returns, and the ache in his jaw vanishes. Harry stands up and continues to his office, unaware that his body has just provided a textbook demonstration of stable angina equivalence. So doctors, I know you would have seen or had patients come to you and they describe similar symptoms, I'm sure. So for patients like Harry, these symptoms are just as significant as the crushing chest pain that we would have heard in the presentation before. Because they disappear with rest, they are often missed or they are delayed in terms of their diagnosis. And this could be an indication of some underlying coronary artery disease. So, how can we assist this patient? I'm just giving you a quick, I don't know if you can, is it too busy? This is just a quick listing of the angina equivalents. Some of them I just mentioned before. So we're seeing the dyspnea, the fatigue and the exhaustion, the upper body discomfort, the GI symptoms, the profuse sweating, and the lightheadedness or dizziness. So you know all the telltale signs. So how can we at SERVIER assist this patient, with your help? Well, we have Vastoral OD80 because we know the importance, when the patient has these multimorbidities, the importance of control and adherence for the patient's life. So Vastoral OD80 is indicated for the reduction and control of angina attacks. It's also indicated for the improving of the exercise capacity and allowing the patients to be more adherent to their treatment. So this is really very important, and let me show you some of the reasons why you want to ensure that Vastoral OD80 is included in your treatment regimen for patients like these. You would have seen from the video just a while ago how Vastoral works at the cellular level by switching in the Krebs cycle, by switching from the fatty acid beta oxidation over to the glucose oxidation. And simply doing this, the patient will get about 33% more ATP production, hands down. But when it comes to managing these patients who come to you with angina equivalence or angina, you are fully aware, I'm sure, that there is a gap between energy supply and energy demand. And you would possibly reach very quickly for a hemodynamic agent like a beta blocker, CCB, etc., right? Yes. But at the same time, you can also utilize Vastoral OD80 to actually elevate that energy supply, and therefore you're able to bridge the gap between demand and supply, so there is actually no gap and there will be no symptoms and the patients will be symptom-free. So that is basically now being seen more frequently in clinical studies where the utilization of a Vasterel, for example, to tackle the problem from the demand and the supply as early as possible to relieve the patients of their symptoms over a period of time. By doing so, there was a study done in 2023. We call it the VGood. They call it the LATAM. It actually shows that after 3 months of treatment with Vasterel OD80, you're able to reduce angina symptoms or angina events by 80% within 3 months. So you probably wonder, rather than going sequential in terms of treating these patients, you start with a beta blocker, and then you see if the symptoms alleviate, then you add a Vasterel. The new concept now in these studies is that they're starting the patient simultaneously. So right from the start, the patient is going to get that dramatic change in the equation, energy demand, energy supply. And once a gap is closed, you're going to be able to, you're seeing changes, dramatic changes very quickly in these patients. In fact, in the same study, at the first visit, when they asked the patients in this study, over 1,000 patients, did you have angina in the previous 2 weeks? At the first visit, only 15% of the patients were able to say no. At the third visit, which is around 3 months after, that amount of patients shot up to 73%. So the dramatic changes that you can expect just by having Vasterel OD80 on board, it is dramatic. It's really very potent. The other indication of Vasterel OD80 is to enhance the exercise tolerability or exercise capacity of the patients. So in just 3 months, what you're looking at is, yes, the same Harry walking up that hill to his office. Rather than having moderate limitations, which you would probably say he had moderate limitations, if he were on a Vasterel OD80, that moderate limitation would actually, within a short period of time, become slight. So he probably wouldn't even have to stop and sit on that bench. So you're making a dramatic change in the life of your patients by about 58% improvement in his exercise capacity. But not only are you allowing the patient an improvement in their ability to do exercise, just by having Vasterel OD80 on board, you're going to see an improvement of maybe about 4 METs in their ability to do more activities. And very important to point out on this slide is that exercise capacity is the most powerful predictor of mortality among established risk factors for cardiovascular disease. That is very, very important to note. Also the fact that each MET, 1 MET of improvement in your patients confers a 12% increase in their survival rate. And as you remember, we're here to enhance and improve the life of your patients by control and adherence, by reducing cardiovascular risk and improving their quality of life. Now, I know Dr. Elliott also spoke about stenting, and he also mentioned that there are sometimes patients will recur in terms of their angina symptoms. They also did a study looking at patients who had done stenting, and we know that around 1/3 of the patients who do this process, this bypass surgery, within a year they do have recurrent in terms of their angina. And what they found is that Vasterel OD80 would work with both these patients and patients who were naive to stenting. So even if you have a patient before you and you realize that, they got a stent before and they present it to you, we have evidence here which actually shows that Vasterel does assist these patients still, despite the fact that they had a prior operation. I know that you would possibly have many options to utilize in terms of treating these patients. And I just wanted you to look at a simple comparison between Vasterel OD80 and ranolazine. I know sometimes you're not sure what to do, which one to go for, but the evidence is here in terms of the comparison that Vasteril actually provides more benefits for these patients with angina or angina equivalents in the studies that we have seen, with chronic coronary syndrome. So you're looking at a reduction in angina attacks of 81% with Vasteril OD80 as compared to 53%. You're looking at improvement in exercise capacity. We're looking at 39 seconds as compared to 23. In terms of interactions, we can't find any other product that Vasteril interacts with at all. Yet still you see a long list over there. And in terms of cost, it is quite affordable. Vasteril is pretty affordable, I can assure you. And you're looking at a twice cost down there. So I just wanted to throw that into the mix. Okay, guys? Doctors, SERVIER has been in the business for over 70 years. They have invested quite a bit in terms of investment, in terms of research and development. So their products are on the cutting edge. What you're looking at is a capsule, the Vasteril OD80 capsule, which is specially formulated. It is like impossible to replicate. So anybody trying to do that they would have to be working at SERVIER, all right? So the fact is we have technology which ensures that your patients get the therapeutic dose for the full 24 hours. And what this does is to provide a 97% improvement in terms of adherence after 3 months. So you can rest assured your patients just take one tablet for the day and they will get the response that you are looking for, guaranteed. Now, if the patient were on the 35 MR, yes, they have generics. I know my doctors will remind me, like Dr. Geraldo will remind me of my generics all the time. But what I can assure you is that the evidence from the Etalon study done in 2011, the outcome of the generics compared to this brand it really is pale. And you're talking about a life-changing event here. So to take a risk of even recommending a generic, it really does not put the patient at the center of everything that we do. So we're just trying to implore you. This is a life-threatening condition. It's very critical that the patient gets the best care. And we are providing you with the very best. So please remember that when you prescribe. And finally, just remember the benefits that this one little capsule, it actually improves adherence so much, and it is easy to take. You can't find any interactions with anything else. And believe you me, you are going to be finding that the patients will do very well on the OD80. So it's a good opportunity for you to consider moving over to the OD80. All right? Thank you.
Thank you, Clifton, and a huge thank you to our first presenter, Dr. Victor Elliott. So if you could join me in raising a round of applause for our first presenter, and I hope you are taking notes. And for those of you who have questions for our first presenter, please hold on to those questions, put them in the chat on Zoom, because we will be handling the questions for his presentation, and after the second presentation, we'll be taking the questions for both. So, without further ado, it is my honor to introduce to you our second and final presenter for the evening, who has asked us to keep his intro succinct. So, out of respect, I will honor that. Dr. Delroy Frey. He's a consultant, surgeon, clinical coordinator at the Western Regional Health Authority. He's a director for the Western Regional Health Authority and an associate lecturer at the University of the West Indies in surgery. Dr. Frey is indeed an ideal individual to share on the topic that we will be hearing more on shortly. His topic will be looking at the legs a pathway to the heart, connections between chronic venous insufficiency and cardiovascular disease. Without further ado, can you help me welcome Dr. Delroy Frey, who is joining us on Zoom. Dr. Frey, over to you.
Good night, everyone. It's a pleasure to be here. Let me share my slides with you. All right. Right, can you hear me very well?
Hi, Doc. Not
Yep,
seeing
great,
your
great.
screen.
So as I said, it's a pleasure to be here. I know your brain
Doc.
is packed. Hello?
Hi, Doc. Dr. Frey, not seeing your screen.
Oh. I wonder where it went. How about that now?
Yes, we're seeing it now.
All right, let me put it in the presentation mode. Yep.
All right, seeing it, Doc.
All right, I want to remove this one from here. There is something at this side here, okay, obstructing it.
Is it the chat?
No. All right, that's good now. How is
No.
that?
You're not in slideshow view. You came out.
All right, that's it now.
Yeah, we're seeing the poll question now. Yeah.
Great.
Perfect.
Now you have just heard a lot of knowledge. I don't know if your brain can take any more. And I want to thank Dr. Elliott for that excellent presentation. So he has outlined how important it is for the heart to function properly, for us to be healthy. My job is going to look at the vein, and I'm sure you're going to ask yourself the question, how are the two related? But if you remember, we'll go back to some basic anatomy, histology, stuff like that, and we'll be able to see what is going on. Now, I'm going to talk about this patient profile. I don't need you to make any suggestion at this point. I want you to bear this in mind as we go through this presentation. And this is a 48-year-old teacher with a BMI of 28 presented for routine medical for job employment. On examination, it was noted that telangiectasia of her right thigh. Otherwise, she was perfectly normal on examination. Question, bear this in mind. Should there be any treatment intervention at this stage? And what other investigations might be necessary to predict any adverse long-term outcome? Now, bear that in mind. And I'll pose this question to you. Is there strong evidence that untreated chronic venous disease at the onset can lead to adverse cardiovascular events? Bear that in mind. Very important. Now, this presentation that I'm going to go through is really a summary of the 19th World Congress of International Union of Phlebology, and it's in Istanbul, Turkey, in September 2022. Now, in that, at that conference, a lot of research came into vogue that highlight the correlation between chronic venous disease and cardiovascular disease. Now, when I look at this, so most of what I'm going to tell you came from that lecture. And I found it very intriguing myself because I, apart from the basic anatomy, I was wondering, how are we going to link the two? The legs are a pathway to the heart, connections between chronic venous insufficiency and cardiovascular disease. Naomi Hamburg in 2021, editorial in the European Heart Journal, noted that the legs are the pathway to the heart. The editorial described the shared risk factors and shared pathophysiology between chronic venous disease and cardiovascular disease. In both conditions, obesity, smoking, aging, and diabetes contributed to the disease process through endothelial dysfunction, inflammation, and thrombosis. Now, look at that diagram. On my left, you can see a vein with a nice valve with a smooth wall there. And if this vein becomes diseased by, venous insufficiency, the clinical manifestations are going to be seen, and we all know it from the SEEP classification, which I'll summarize: telangiectase, edema, hyperpigmentation, and ulcers. And that is what we'll see. On the cardiovascular side, if the vessel is affected, as you have just heard earlier, it will result in mortality, heart failure, and on the arterial side, peripheral artery disease. Now, my next slide shows you the sort of pathway here, and we'll go back to a little bit of anatomy here. So the heart pumps blood around the body. The veins picks it up. And look at the unique anatomy of the veins in the lower limbs. Lower limb drainage is via two sources, the superficial veins and the deep veins. And it's very important for proper functioning that the flow back to the heart is controlled by valves that are in those veins that we teach in anatomy where these valves are. In the superficial system, from the medial side of that leg, you have three inconstant veins, 5, 10, 15 centimeters from the medial malleolus. You have a valve at the saphino-popliteal junction, and then the main valve in the saphino-femoral junction. And along with that, the deep system has valves, but the calf muscle pump is going to be very important in order to push back that blood to the heart. So if you look at that anatomy, you're going to see now that they are interrelated. The heart pumps out, the veins brings it back up there, and both set of conduit must be maintained in proper health. The key factor that was mentioned from Dr. Elliott talk as well, the key barrier between the blood and the vessel wall, both in the veins and the arteries, is the endothelium. It acts as a barrier. To maintain good health, that endothelium must be kept healthy. And as you can see from the diagram on my right, going towards the heart, the blood vessels and those fine vessels that are going up, and we heard about the smaller vessels in the heart itself. We thought it was the major ones that can be troublesome, but the minor ones can be troublesome as well. And it's absolutely important that we are going to maintain that endothelial barrier between blood and the vessel wall. Now, look at the sheer pathophysiology and the sheer risk between the venous side and the vascular side. Sheer risk: obesity, aging, smoking, diabetes. We know all about that. But the sheer pathophysiology has to do with three very important components. One, endothelial function. So if the endothelium becomes dysfunctional, a cascade of events occurs. What is that? Inflammation, thrombosis. And I'm going to tell you another aspect of that. Once there is inflammation, you're going to get not only to the local vessel itself, but systemic inflammation as well that can affect vasculature everywhere in the body. We know from, in the past, I've given this lecture, and we talk about, what is happening on the venous side. And it's a cascade of events that is both anatomical and at the cellular level. I'm not going to bore you with the detail, but just to remind you that on the venous side, there are changes in the biomechanical environment of the veins that, facilitate a series of inflammatory cellular responses, which ultimately will result in valvular dysfunction and remodeling. And if you look at this diagram across here, endothelial activation and dysfunction is going to liberate your inflammatory mediators such as your cytokines, your leukocytes, your lymphocytes, etc. All of those that deals with inflammation. And you get valvular dysfunction. Coupling with that will lead to venous insufficiency. And of course, from the bottom, as you can see, the genetic factors that are there that is going to trigger that response. So the question is, from that conference that I told you about, evidence suggests that chronic venous disease may be a cardiovascular disorder. That is the premise that they start out with. As with chronic venous disease, they are prone to developing arterial atherosclerosis and venous thrombosis. That is cardiovascular disease. This may be partly explained by the shared risks that I've showed you before. And as you can see, the common pathophysiology is going to affect both type of vessels. From the venous side, the summary of it is captured very nicely on this slide. The inflammation that occurs is due to venous hypertension from both the valvular failure side and at the cellular level. And once this happens, you're going to get inflammation. And what is going to happen? Inflammation, you get abnormal permeability of capillaries, remodeling of your venous valves and wall, and finally, by the time you reach down to C5, 6, you get necrosis of skin capillaries, ulcer formation, so you get the so-called symptoms that are related to this. When you look from the arterial side, look at this. You can paste this diagram right in your brain. Paste most diagrams so you can remember it. We talk about the traditional risk factors, the non-traditional risk factors, genetic predisposition, and the unknown factors. But the local factor I want to stress here is referred to as the shear stress. And what this shear stress does, it damages. It damages, and I'll emphasize that this shear stress damages the endothelium, and you get endothelial dysfunction. And we refer to this as the risk of the risk factors. And you heard this before, but I explained it a little more. This is the result of the endothelial dysfunction. Vascular lesion and remodeling, inflammation, vasoconstriction, thrombosis, plaque formation, rupture, erosion, and that is called to cause embolization and give you all the effects that we see from the arterial side, especially in the heart and the peripheral arteries that are going to be affected by that pathophysiology based on just our endothelial dysfunction. And this is what I'm telling you about. All the other factors, but the sheer stress is what is going to disrupt it and cause the plaques to disrupt and erosion to occur, and a cascade of events will follow. So you have to follow me with these diagrams. We'll cut the presentation short, less words to talk about. On the venous side, what do we see? Why are we worried about this? We must be worried about this. If there's a correlation between the venous incompetence that we are seeing, chronic venous insufficiency, and the cardiovascular disease, how does it relate to the population? Well, look at that diagram on my left there. There is a high prevalence in the population. And the blue there represent men and women. And if you look at the age group, 40 to 49, you stretch it right up to 70 to 80. Both males and females are affected by chronic venous insufficiency. And the co-prevalence now with cardiovascular risk factors, as you can see from that little diagram from our histology, the arterial side, how it blends into the venous side, it causes a difference. So, in order to convince us, as I was convinced, I have to convince you, I looked at the evidence that were presented at that 19th World Conference in Istanbul that I told you about. And they look at the cumulative incidence of all cause of death. And this was plotted against, they followed the patient up for years. And what they did was to look at the venous presentation as it relates to, no clinical signs, telangiectasia, C1, varicose vein, C2. And as you can see from the diagram there, the red line shows that a lot of patients, the mortality and cause of death was higher in the patients who had higher SEEP classification of their venous disorder. And I want to pause there and allow you to absorb that point. Because I know some bright person, or probably all of you in this platform, are going to say, Dr. Frey, that don't tell me anything, because what if those patients has, the traditional, risk for cardiovascular disease and death, like, the obesity, the diabetes, the high cholesterol, etc., etc. Then what it means is that, we don't have any legs to stand on there. But let's go on a little further and see what happened as they develop the theory behind this and the practical outcome that they have seen from studies. And what they look at, you see, they look at the relationship between chronic venous insufficiency and the presence of cardiovascular disease. And again, now they look into looking at, this is high statistics. I don't want to get your mind into this. But let's say that is that chronic venous insufficiency and the clinical outcome prediction over 10 years for cardiovascular risk, and they use the Framingham risk score. That's a statistical thing, you can look at later. And they look at each of the SEEP classification and compare it, to one set of patients who had, no risk factors versus the traditional risk factors, and those who have just venous disease alone. And again, look at the diagram. Advanced SEEP classification, the cumulative incidence of the cause of death was higher if you vary anywhere from SEEP 3 right down to SEEP 6. And you can note the reference there Later on, you can have a look at it. And this is another aspect of it that try to pull out and differentiate them just to remove the confounding factors that might have affected the outcome and to see if just venous disease alone is related to cardiovascular death. And this diagram puts it very nicely for us. And on the vertical line, you see the different mortality, heart rate, coronary artery syndrome, ischemic stroke, all of those. And the risks of all cause of mortality and cardiovascular events in patients with versus without varicose vein, stratified by varicose vein severity grade alone. And what they found, again, if you look at it, if you adjust the risk ratio there, what you're going to see is that those with the higher CEAP value, there was a higher risk of cardiovascular events in those patients, as you can see highlighted there in the red. Now, it's important now, this is a little deeper in statistics, where they use the Kaplan-Meier survival estimate again, and they rank the patient, and they look at them over 12-year survival between those with varicose vein match control cohort against estimates 12-year survival between patient with varicose vein categorized by disease severity and match control cohort. And again, what we saw from this study again is that the higher CEAP classification was related to more cardiovascular death as well. So let us look at some of the adverse outcome from those studies as it ranks with varicose vein and the different arterial disease that one can get. And the first one they look at was deep venous thrombosis. And again, you study the control group and look at the group with varicose vein. And what are we seeing there from that top right-hand one? That the cumulative probability of deep venous thrombosis was higher. And I'm sure a lot of people are going to say, oh, we know that long time in the venous varicose vein group. But when we look at peripheral arterial disease, we see the same trend. Look at the control group, look at the varicose vein group, same trend we are seeing. And look, embolism that can be fatal. Again, patients in the varicose vein group were higher than those in the control group. So I'm going to pause here, right here. And right at about here, they came to this conclusion that we can now entertain chronic venous deficiency as a cardiovascular risk that can be added to the old-fashioned cardiovascular risk that we know about. So what does this mean? This means we are going to be more astute in looking at our patients and to see how we can identify. And I remember that case I showed you, and we're going to look at it at the end, what is going to, important in order to prevent long-term. And if you look at the studies that they did, 10, 12 years, that's significant study. So why measure cardiovascular risk with vascular stiffness? You have to measure that so that it can give you an idea, and these are the findings that came out of it, and I just flash them there for you. So based on this multimorbidity testing, now, would this patient require any intervention for venous insufficiency? And I don't want you to answer yet. I want you to just look at that. We know about the different treatment options for patients with chronic venous insufficiency. We know of pharmacologic option. We know about compression, etc. We know about minimal surgical intervention, laser, etc., all of those things. Is it important that we intervene early in order to prevent the long-term outcome from, these cardiovascular disease? So, if there's any slide I want you to keep in your mind, this is the slide I want you to keep in your mind. Look at the top. There's varicose veins. What is its prevalence? In the population, varicose veins prevalence somewhere between 38 to 90% depend on the population you're dealing with. What the healthcare costs is significant. Look at it. And not to mention the quality of life. Now, why is this important to identify early and to deal with it? There was a study done at Edinburgh University where they look at the silent progression of, venous disease over a 13-year period. And what they found is that patients were moving from, one level of SEEP to a higher level of SEEP. 57% of the patient move. But bear this in mind, untreated chronic venous disease, 40% of them will progress to C4 to C6 level. And as you can see from the illustration that I gave you before, it has a strong correlation with cardiovascular events and all of the arterial side of the disease process that can cause morbidity and mortality. So, colleagues, based on this study, and this is the one study I didn't get a chance to look at anymore, we have to intervene early to prevent progression because the statistics there tell us what is going on. So, from the pathophysiological point of view, we have to introduce treatment. Why? We have to decrease the inflammation. We have to decrease the venous hypertension that triggers the inflammation and the cascade. And if you look at the slide there on a normal venous pressure, how it looks compared to one with venous hypertension, you don't want your patient to end up in that situation. We must get the vascular, minimize that vascular remodeling to minimize cardiovascular implication. Now, drugs available. We all know about the veno-active drugs. These reduce capillary permeability, decrease the inflammatory mediators, and these veno-active drugs are going to improve our venous tone and minimize the cascade of event. Of course, there are other substances out there that can do it, as I mentioned here, as you can see them flashing up. But if you look at a Cochrane study that look at all of these things, and from the Cochrane study, they found that the most important veno-active drug is micronized purified flavonoid fraction, MPFF. And as you can see, that is how from that diagram tells a lot how it's work. It is preserving your venous endothelium, which is important to minimize the disease process. Systemic inflammation will be decreased. And if you combine that with compression stocking, early intervention, you can prevent progression of the disease. So, colleagues, chronic venous disease demands a translational approach from molecular biology to therapeutic intervention. Will we adopt strategies that transform its natural history? Or are we going to remain as bystander? And somebody might be thinking, oh, this is really selling the product. But if you know about the Cochrane study, They do a large systemic analysis of things, you know, to come up with the final solution. So it's not, you know, you can't tell them what to do. It's data driven and it's important. Now, let's go back now to that case study. Now, all we know about this patient that I gave you is that this patient has telangiectasia. She's 48 years old. She has a BMI of 28. Now, should there be any treatment intervention at this stage? And let me tell you why I choose a case like this. I could have choose a SEEP classification of 4 or 5. I could have done that. But I want you to look at something simple as this, because, you know, if you look at a young person and you look at this young person with telangiectasia, you might say, oh boy, why not send to the dermatologist and let them inject some, you know, hypertonic saline or something like that to give some cosmesis to the leg, isn't it? But I need you, when you see a patient like this, that's why I create this one. I created from AI because I couldn't get consent to put a real patient at a short notice. You must go into the detailed history. You want to know if there are any comorbidities. Look, diabetes, high blood pressure, high cholesterol, etc., all the things we teach you. And if this patient that seems so simple has that history, any of those comorbidities, I would say to you, this is where you're going to start your treatment to prevent progression of that venous disease. And why is it important? The evidence from the Edinburgh study. After 13 years, everybody going to move to, if untreated, to higher SEEP level. And if you are SEEP 3 or 4, 40% of them, you know, at SEEP 3 is going to end up at 4 and 5. And once the venous endothelium is breached, you remember what happens to the mortality that comes out of this. So it's very important. The legs look far away from the heart, but the correlation, it is scientific, and it is very, very important that we understand. So what does this mean, colleagues? It means that we are going to take a closer look at our patient, classify the SEEP level, and start your treatment early. And you have another risk factor for cardiovascular disease now. It's chronic venous disease from the Istanbul, Turkey symposium in September 2022. Absolutely important. And I think that is enough in one evening. Let me see if I have any other slides there. But that's really what I want to highlight to you this evening. Thank you.
Chronic venous disease and hemorrhoidal disease are two different diseases in which venous inflammation is involved. Leukocytes in the microcirculatory system play a key role in vein wall weakening and venous valve damage. The inflammation cascade begins with the release of inflammatory mediators, such as bradykinin, histamine, phosphodiesterases, leukotriene B4, and reactive oxygen species, and activation of inflammatory pathways that lead to the leukocyte activation. These activated leukocytes begin to roll and stick to the endothelial cells, increasing permeability due to the release of reactive oxygen species and hydrolytic enzymes. This leads to interstitial edema, which compresses the capillaries and leads to ischemia and hypoxia of the capillaries. Chronic ischemia and perfusion of the capillaries triggers a pathological cascade. The result of chronic venous disease is the dilation of veins and remodeling of the valves, which causes blood to pool in the legs, thus producing symptoms of leg pain and heaviness. In hemorrhoidal disease, severe inflammation occurring in the vascular wall and surrounding connective tissue results in significant pathological changes, including abnormal vein dilation, degeneration of collagen fibers, and distortion of the anal subepithelial muscle. Daflon has a unique combination of 5 flavonoids that act in synergy to target the venous inflammatory pathways. Daflon acts at the core of the venous inflammatory cascade by reducing the number of rolling and sticking leukocytes, increasing functional capillary density, and reducing the vein diameter. Studies have shown that Daflon is more effective in improving these microcirculatory variables compared with diosmin. By inhibiting bradykinin and histamine release, Daflon also reduces vascular permeability to macromolecules, thus preventing the infiltration of granulocytes and macrophages and stopping the rarefication of capillaries. Furthermore, Daflon also acts on the inflammatory processes in venous valves and the vein wall by decreasing the infiltration of the granulocytes and macrophages into the vein wall and valves, and by reducing the oxidative stress. In venous hypertension models, Daflon was able to delay the development of reflux and suppress the damage to the valve structures. In patients with chronic venous disease, treatment with Daflon was associated with elimination of transient reflux in the great saphenous vein, reduction in the intensity of chronic venous disease symptoms, and improvement in the patient's quality of life. These results show that Daflon has the potential to prevent the development and progression of chronic venous disease and its different manifestations, as stated in the latest international guidelines. In addition to its unique composition, Daflon is absorbed better compared with other flavonoid fractions due to its superior micronization process, resulting in particles less than 2 micrometers in size. Studies have shown that not all micronized flavonoid fractions are the same, which may explain Daflon's superior beneficial effects compared with diosmin. The result is that Daflon reduces the symptoms of tired, heavy, painful legs in patients with chronic venous disease, and anal pain, itching, and discomfort in patients with hemorrhoidal disease.
Right, at this time, first and foremost, thank you so much, Dr. Frey, for that very informative presentation. And at this time, we're going to be joined by Fiona online, who will be sharing a very brief spotlight, and then we'll wrap up with the question and answers. Fiona?
Need to unmute Fiona.
Good evening, everyone. Can I go ahead now?
Yes, please go ahead.
Okay. Good evening, everyone. I am Fiona. Thank you once again for coming out to join us this evening, whether you're online or face-to-face. Today, I want to highlight something that is of overlooked in practice, the link between cardiovascular and chronic venous disease and how Daflon 1000 milligram fits into that story. Meet Miss Brown. She's a 64-year-old shopkeeper in Spanish Town. She's on her feet all day, standing behind the counter, and by evening, her legs are swollen, heavy, and painful. She tells our doctor, Doc, I can't manage the swelling no more. By evening, my foot them heavy like lead. No, Miss Brown isn't new to the health system. She has hypertension, she's pre-diabetic, and she has high cholesterol. But when she comes to the doctor, she doesn't complain about her sugar or her pressure. What really drives her to seek help is her legs. We often see patients like Miss Brown and focus on her legs alone, but chronic venous disease and cardiovascular risk factors go hand in hand. The same risk factors that drive hypertension, diabetes, and dyslipidemia are the ones that worsen venous disease. So, swollen legs, that's not just a cosmetic issue, it's a vascular red flag. When we treat chronic venous disease as just poor circulation in the legs, we miss the bigger picture. Venous disease is inflammatory, progressive, and systemic. Patients with chronic venous disease are at higher risk for all cause death. Miss Brown's swollen ankles are telling us more than she realizes. Chronic venous disease doesn't start overnight. It's a silent, creeping progression, one that is often ignored until it's too late. It begins at C0, where you feel the symptoms but see nothing. By C1, tiny spider veins start to show. But how many of our patients, like Miss Brown, ignore these signs? How many of them say it's just cosmetic, while something deeper is happening in their veins? By C2, the veins are no longer hiding. They are bulging, painful, twisting under the skin, and then the swelling starts at C3, where ankles puff up by evening, shoes stop fitting, and the discomfort grows. If left untreated, skin begin to change, dark, harden, discolored, and this is C4. And beyond that, C5 and C6, ulcers, open wounds that refuse to heal, constant pain, reduced mobility, a life forever changed. When our patients like Miss Brown stand before us, telling us that her legs are heavy, painful, and swollen, where is she now? Is it C2? Is it C3? And if we don't intervene, where will she be next year or the next 5 years from now? Recognizing the stage means we can intervene early and effectively. This is where Duflan comes in. Duflan has evidence that it works at all stages of venous insufficiency and has strong support by international guidelines. It is the only venoactive drug that is recommended at all stages of chronic venous disease based on clinical evidence. Many of our patients with chronic venous disease, like Miss Brown, are also at high risk for hemorrhoids. Same potential risk factors, same venous fragility, same inflammatory pathway. This is where Duflan 1000 milligrams stands out again. It is not limited to chronic venous disease. It is actually the phlebotomic recommended in all stages of hemorrhoidal disease from grade 1 through to grade 4. That means whether the patient is just starting with the discomfort and occasional bleeding, or they're already in advanced stages and may eventually need surgery, Duflan has a role. It improves symptoms, reduces inflammation, and supports recovery at every stage. Duflan 1000 milligrams is used in chronic venous disease patients as early as they have symptoms like pain, heaviness, cramping, and in hemorrhoidal disease patients as early as a painless bleeding. In chronic venous disease, first, yes, we tell Miss Brown to elevate her legs, avoid long standing, and to exercise. But let's be real. How many sitting and elevating can she realistically do? And will that alone reduce her symptoms, reverse her symptoms? Second, compression stockings. But in this heat, in Jamaica, you and I both know adherence is a struggle. The patients will buy one pair and never wear them again. That's why international guidelines strongly recommend venoactive drugs, and Doflon 1000 milligrams stands at the top of that list because Doflon doesn't just treat the symptoms, it works on the cause, improving venous tone, reducing inflammation, and strengthening the vein walls. So what happens when Miss Brown starts Doflon 1000 milligrams? Within weeks, she notices her legs feel lighter, the swelling goes down, and her pain is significantly reduced. At the core of our improved comfort is Doflon 1000 milligram, improving venous tone, reducing inflammation, and protecting the microcirculation. And if hemorrhoidal disease is the problem, in just 4 days, Doflon ceased bleeding in 92% of patients, and after 7 days, pain is reduced by 84%. That's why Miss Brown will keep taking her Doflon because she actually feels the benefit. And adherence is everything when we're managing chronic conditions. The evidence is clear. Doflon 1000 milligrams work where it matters. In the Kerenco study, they looked at the clinical efficacy of Doflon 1000 milligram in patients with symptomatic chronic venous disease. They found that leg pain dropped from 5.95 at week 0 to 1.7 in just 2 months. Doctors, Doflon is the most recommended by experts in all stages of chronic venous disease, having powerful anti-inflammatory action at the early stages, and we're talking about C0 to C1. Patients might not have visible varicose veins yet, but they're already complaining about symptoms like pain, heaviness, and cramps. Doflon 1000 milligram address the underlying venous inflammation and dysfunction from early. Doflon reduced venous reflux by 48%, which tells us we're not just masking symptoms, we're actually improving venous tone and circulation. Doflon reduces pain by 100%, heaviness by 89%, and cramps by 94%. Now, as the disease progresses into C2 and C3, we're dealing with visible varicose veins and edema. What's important here is that Doflon doesn't just give quick relief, it gives progressive, sustained improvement over time. By 3 to 6 months, we're seeing a 63% reduction in pain and a 73% reduction in heaviness. And importantly, a real reduction in ankle circumference, meaning the edema is objectively improving. When compared to other venoactive options like Roscos or Diazmin, Doflon shows superior efficacy, up to 4 times more effective in reducing edema. Doflon is not just symptomatic relief, it is one of the most effective options for edema control in chronic venous disease. Doctors, even in more advanced stages, Doflon continues to show strong clinical benefit. In C4 patients with skin changes, we see a 66% reduction in color changes and the area of skin lesions. And in the most severe stages, where there is venous ulcer, Doflon actually accelerates healing by reducing healing time by 35 days. That's significant because these are the patients who are most difficult to manage and most at risk for complication. What this really shows is that Doflon 1000 milligram is not stage specific. It's a full spectrum solution for chronic venous disease, from early symptoms to advanced complications. So here is what this means for you, doctors. When you prescribe Doflon 1000 milligrams, you are not relieving symptoms. You are supporting long-term vascular health, slowing disease progression, and indirectly tackling cardiovascular risk. For patients like Miss Brown, it's not just about lighter legs, it's about protecting their future. So the next time you see a patient with chronic venous disease, think beyond the legs. Think about their vessels, their heart, their overall vascular burden. Doflon 1000 milligrams gives us the opportunity to treat the symptoms they feel and the risk they don't see. Doflon is the original MPFF with smaller homogeneous particle sizes, ensuring better absorption at the intestinal level. This means a rapid and superior relief of signs and symptoms, which your patients like Miss Brown desperately need with good tolerability. No generic has been able to prove the presence of all 5 flavonoid fractions and typically only have 2. Their particle sizes are also larger and not homogeneous. Do not fall for copies. Your patients deserve the best treatment with the unbeatable Doflon 1000 milligram for balance of efficacy and tolerability, improving control and adherence, and allowing patients like Miss Brown a better quality of life. Doflon provides significant venoprotective and anti-inflammatory action for further control. It's very efficacious at all stages of chronic venous disease and hemorrhoidal disease, and it provides control of complications for an improved quality of life. In your patients with chronic venous disease, for the 1000 milligram, it's 1 tablet daily for 2 months. And in a hemorrhoidal crisis, it's 3 tablets for the first 4 days, followed by 2 tablets for 3 days. And very important, the maintenance dose of 1 tablet, taking the patients up to 2 months. And if 500 milligram is being used for your chronic venous disease patients, it's 2 tablets daily for a minimum of 2 months. And in a hemorrhoidal crisis, 6 tablets for the first 4 days, followed by 4 tablets for 3 days, and then they're maintained on 2 tablets. Doctors, this is a difference that Doflon 1000 milligram makes in your patients like Miss Brown. Remember how she looked at in the beginning? From early symptoms to advanced disease, we're moving patients from discomfort to control to relief. Thank you.
Thank you, Fee. All right, we've come to almost the end. I know there may be a few questions rather. In the chat on Zoom, there are about 3. So I will present them to our speakers. So one of the first questions that we got, one of 4 questions, goes to Dr. Elliott concerning the tests that were shared, the calcium, all of those tests that you had shared. One physician is asking, how affordable is this for the average patient?
Affordability is always a thing in our society. So essentially, if you go through the steps, when you assess your patient and you assess and believe they have some form of coronary artery disease, you're going to send them for, say, stress test imaging, for example. That's not too expensive. The coronary CT scan is a bit more expensive. I actually don't have the prices. And then that's why, again, you see, the whole thing is if you already assess them at high risk, there's no need to send them for all these other little tests. Just send them for the angiogram, because then it becomes cost saving. Because you think they're high risk, you're going to send them for the stress test and then send them to the other things, and then they're going to end up doing the angiogram. So it'd be things they're spent money for, which they don't need. And as I said, I kind of just use my own little guideline in which if the test came back negative, will I believe it? So that just helps me personally to sometimes just go to the more direct gold standard. So it does cost. We know medical care costs, investigations costs. The CT scan itself is not that much higher than the CT of high resolution CT or so. So it's not way above. Neither is the MRI, as we know, MRIs cost a little more than CTs. But then again, the cardiac MRI is not astronomically above the MRI of other organs. Though it does take a little bit more, so it's going to be a little bit more expensive than, say, a plain brain MRI, but it's not exorbitant.
Of the endotype of the ANOCA.
Okay, he's asking what is our experience in terms of finding of the endotype of the ANOCA. As I said, what I've seen enough of these cases. I go to in terms of, I've had some times in the cath lab between partners and UE. Almost everybody I do, you look on the history, you say, yes, I'm going to find somebody with coronary artery disease, and none of them have. Yet they're continuing to have angina. So we do see it. I would like to say at least one case per week, I am finding it. So it is there, it is real. And in my mind, my first step was to think, okay, maybe it's vasospasm or microvascular disease. So yes, I put them on the nitrate, I put them on trimetazidine, I put them on ranolazine. I tend not to use calcium channel blockers as often, depending on the patient. But I'm using more and more verapamil though, of course, than diltiazem. What I'm realizing is that we do need to get the appropriate answer, because like everything else, it means I'm putting patients on medications. On some of them, I don't know if they need to be on it or if I have them on the right medication. So as I said, it's a challenge when preparing this study, and it's actually started a bit before that, not the study presentation, in which the challenge came across to me that, look, we need to do something to get more information for our patients here. But I can tell you a lot of places still not doing it. The numbers are growing, but the guidelines are saying we need to get it done.
Thank you so much, Dr. Elliott. I have a question here directed at Dr. Frey. Is it possible to get Dr. Frey's camera? No? Okay. Okay, so Dr. Frey, this one goes to you. What other investigations would be best for this patient with telangiectasias, spider veins? What other investigations would be best for this patient in the case you presented?
Okay, yes, that's a very good question. In fact, I know they would ask that question. For me, you're going to take a thorough history. If there is symptomatology of venous congestion, it means that you start simple. A Doppler ultrasound to look at that venous mapping and to see if there's any early evidence of valvular incompetence that you can address. And a patient like that, early like that, compression, stockings, and of course, a Doppler would make a big difference there. So you have to weigh the history, weigh the symptomatology to know how you move from there. Thank you.
Thank you, Dr. Frey. Another question for you, Doc. Can exercise help to resolve venous insufficiency?
Oh,
And I'll just add the second question that's here. Is there a role for doxium in the management of venous insufficiency?
Okay, exercise certainly is helpful because remember I told you that part of the pathway of the whole anatomy of the venous circulation of the leg is the calf muscle pump is also very important. And once that is active, it helps the situation. What was the second question?
A role for doxium in venous insufficiency management.
I've never used it, so I don't want to comment on that. Thank you.
Okay, Doc. Any questions in the room? I know Dr. Ford has a question here. Is it possible for us to get a microphone for Doc?
Thank you very much. My question is to Dr. Elliott, actually. I have had patients who have been diagnosed clinically here by myself and the radiologist with having ischemic heart disease. And in more than one case, in 3 cases in particular, I referred the patient to doctors in America. And I had the patients on Vastaril. One of the first things all 3 doctors did was take the patients off Vastaril. I went on so far as to send a booklet about Vastaril up to them so they could get familiar with the drug and understand what the drug does. But they said there's no place for Vastaril in the management of ischemic heart disease in the United States. Could you please clarify that for me?
It's because it's not available in the United States. It's one of the few places where the drug doesn't exist. What they have is ranitidine, but also understand ranitidine and trimetazidine work 2 different ways. Initially, they thought they were similar, but they are not. They work 2 different pathways, and you can combine them. So if you have a patient here who goes up on it, they're going to stop it just simply because they can't get it up there. That's just it. They're not familiar with it unless they tend to attend the European meetings. They are not going to know the drug. And a lot of them, some do attend it, a lot of them don't.
Thank you, Dr. Elliott. I have another question for you, Dr. Frey. Does lifting heavy weights increase venous pressure and cause telangiectasia? Is that possible?
That's a good question. Lifting really causes pressure more into the pelvic area, It's not so much on the leg itself. And I think that's where the first question comes in, where with the exercise. But please note very carefully, if you have venous insufficiency that is well established, you have the sign, you fall into one of those SEEP classification, and you're going to do manual work like that, it would be very important that you wear your compression stocking and carry out your work. It's very important, because remember, the whole business of venous pooling is what is going to trigger the process both at the cellular level and at the valvular level, that will trigger the process of inflammation to damage the endothelium, which is what we don't want. So I would advise your patient, if there are manual work and there is evidence that there's venous disease, please encourage them to wear their support stocking along with their pharmacologic agent, and that will make a world of a difference.
Thank you, Dr. Frey. Another question that was placed in the chat was a question as it relates to the side effect of Vastaril OD80. For the doctor who presented that question, well, in our SPCR product insert, listed as a common side effect, strange, but we haven't heard it from our doctors here, is GI disturbance, which is something that it's pretty rare, and we I don't know, for the doctors that are here, you can probably share with me if this is an issue you have seen with your patients. And I'm seeing 2 patients you've seen with, Dr. Elliott mentioned just 2 of his patients, and 2 I'm sure of many So it's actually a quite safe drug to use in your patients, and I think Clifton would have mentioned earlier in terms of drug-drug interactions, 0. So you can feel free for even your male patients who need enhancement of their manhood, they can safely take the Vastorel with their Viagra, etc. But no, I'm so glad you mentioned that, Doc, because it's interesting. The Vastorel is listed as one of the banned substances for athletes because of that powerful improvement in ATP. You can appreciate why they would have to ban it, because it would give the athletes an unfair advantage, allowing them to power out of those, what they call the thing on the ground? The starting blocks. Exactly. But in one specific incident, we heard of an athlete in the Winter Olympics who when they tested, they noticed they picked up trimetazidine in her blood, and she said it was her grandfather's medication that she took, and it may have been on the glass that she drank from. But just to bear in mind, it is so good that they have had to say, listen, athletes, no, it's a no for you. So I have another question here. This one goes to you, Dr. Frey, regarding venous insufficiency once more. How long should the patient with chronic venous insufficiency be treated with Daflon?
Well, that's a good question. Remember, there are lots of treatment options. In fact, you can treat patients for, a long time with Daflon. If you look at the side effect profile, it's very good. However, I want to warn you, there are other treatment options that goes with Daflon as well. If you have C4, C5 disease, you do your venous mapping and you see that is the superficial system that is affected. You can ablate that superficial system. You can do it the whole way, venous stripping, if that is available. In fact, laser is available. A foam injection, glue injection, all of those. And once you have done that, you couple that with still your support stocking and Daflon for a while until it settles down. And I've treated patients like that. And after a year or so, you can gradually wean them off. But the answer is you can keep them on, as long as it's needed to control the disease process. Thank you.
Thank you, Dr. Frey. Dr. Frey, still on venous insufficiency management. A question for you. Any suggestions regarding patients who have chronic venous insufficiency and are at C1, who are on pharmacotherapy but refuse to wear compression stockings?
Well, that patient, C1 disease, they should really wear their compression stockings. But what I would do in that patient, because you see, you have to work with patient, I would do the venous mapping. And if I see any evidence of, valvular incompetence in the superficial system, and there are techniques we can do now, Shiva's technique, where we can literally, just tie off the offending perforator, and that will help a great deal. So you can map the patient and offer them that additive support in terms of surgery that will assist. But as I said, anything that will arrest the disease process is going to be very important for your patient. So always remember that that's a tool that is available for them.
Thank you, Dr. Frey. And I think this is the last question also for you, Dr. Frey. For SLE patients with thrombotic complications, are these pharmacological agents safe for these patients to take?
That is a big question. And the truth is, I'm not sure how it affects. I haven't had, those patients. But what I usually do, we have Google nowadays, you look at the medication those patients are and you cross-check it on Google to make sure you get no drug-drug interaction. And those patients, they usually on a lot of medication, and I would go more conservative with, compression stockings. And as I say, if my mapping tells me that I can intervene minimally by just tying off, a few perforators with compression stocking, I'll probably move towards that. But I would check Daflon with the medication they are taking before I institute it. Thank you.
Okay, thank you so much, Dr. Frey, and to you, Dr. Elliott, and to our doctors who participated in the Q&A, and to you, our audience, who have been online with us and here with us in person at the Terra Nova. So, we've had your attention for over 2 hours, my God, and the bed is calling. But I know tomorrow morning, no doubt, for the remainder of the week, the chance remains that you may come across a patient who fits either of the cases presented this evening that Dr. Elliott shared or Dr. Frey shared. And with this kind of information now comes a great and burning and weighty responsibility on you, the persons who have been empowered tonight, to really screen, go deeper, and to ask those questions to really arrive at a diagnosis and to possibly uncover those patients that could possibly fall through the cracks. And may we suggest from SERVIER 2 helpful allies in your management? Behind me, Vastarel OD80 and Daflon 1000 milligrams, 2 powerful weapons in your armamentarium that you can deploy with your pen and your prescription pads starting tomorrow. I charge you with the responsibility of patient by patient, really arresting those conditions and preventing progression. Ladies and gentlemen, thank you so much for your attention tonight. Keep safe and have a wonderful evening.
In 24 hours, the heart beats over 100,000 times and pumps nearly 9,000 litres of blood to supply the cells with oxygen and nutrients. To contract and relax continuously, the heart muscle cells, the cardiomyocytes, must constantly produce energy in the form of adenosine triphosphate, ATP. In normal conditions, the heart produces between 6 and 35 kilograms of ATP every 24 hours to satisfy the energy demand. When ATP production does not meet the energy demand, there is an imbalance between energy supply and energy demand. This is called myocardial ischemia. Myocardial ischemia is a complex syndrome with multiple causes, which include coronary stenosis, thrombosis, vasospasm, microvascular dysfunction, endothelial dysfunction, and inflammation. Regardless of the causes of myocardial ischemia, it is fundamental to reduce the ischemic burden directly at the cardiac cell level by increasing ATP production. This is precisely what Vastarel 8-TOD does. Vastarel 8-TOD uses an advanced controlled release technology to cover the needs of patients over 24 hours. Its granules are made up of inert core beads that are coated with the active substance, trimetazidine, and covered with a polymer membrane layer. This membrane, which contains micropores, enables the controlled release of trimetazidine. For patient convenience, the controlled release granules are enclosed in a capsule that contains the total daily dose of Vastarel, which is 80 milligrams. This is Vastarel 8-TOD. The treatment regimen is simple. Just 1 capsule of Vastarel 8-TOD once daily in the morning covers the needs of patients for 24 hours. Once in the stomach, the Vastarel 8-TOD capsule dissolves and the coated granules are dispersed into the gastrointestinal tract. There, the micropores of the polymer membrane allow fluid to enter the granules and come into contact with the active substance, which gradually dissolves and is subsequently released by diffusion. Thanks to this advanced controlled release technology, continuous diffusion is achieved, and the absorption phase in the intestinal villi is prolonged. This ensures that Vastarel 80OD's powerful anti-anginal efficacy is maintained over 24 hours. One capsule of Vastarel 80OD per day reduces the ischemic burden directly at the cardiac cell level, where it matters. Over 24 hours, Vastarel 80OD increases ATP production by 33%, reduces acidosis, and enables cardiac cells to function properly. Thanks to this unique mode of action, Vastarel 80OD reduces angina attacks, preserves cardiac function, and improves exercise capacity. By prescribing Vastarel 80OD 1 capsule in the morning, you will provide your angina patients with a simple once-daily treatment regimen and anti-anginal efficacy over 24 hours.